for you?
Yeah, I will introduce you now. Already live stream already started. Thank you. Thank you very much. I would like to say thanks to the Professor Zhu and Professor Dikosi for your support and input to our revolution. Today, this is a third lecture from our two professors, and then we will be having more lecture and more talk regarding with the revolutionary medical training. And today's lecture will be upper limb trauma part 2. Professor Jean-Luc Zhu will be talking about this part 2. After that, we will have a question and answer, and then the discussion. And I think you already know, and then I already introduced you all. These two professors are our father of spine surgery and father of pediatric orthopedic surgery in Myanmar, and they have been helping us for more than 15 years. They have been in Myanmar many times. I think more than 30 times in Myanmar, and now they are very much supporting us for the revolution, and then not only for the academy, but also for the service and future orthopedic development. So that I don't want to take that much time. I would like to hand it over the floor to the Professor Zhu. Professor Zhu, please. Thank you.
Thank you very much. Good morning and good afternoon for you. As I say yesterday, it's always a pleasure to share knowledge with our friend from Burma, and I will continue to speak about the upper limb trauma in children, and this is the second part. This part will concern forearm, wrist, and the proximal part of the radius and ulna. As I said yesterday, the most important thing in the proximal part of radius and ulna and in the elbow is to know the ossification center, the ossification nuclei of the elbow, because it is the only way to do the good diagnosis of the elbow trauma on the humerus, but also on the radius and on the ulna. This is a slide of yesterday, which explains that there are 6 centers of ossification, and it is important to know the age of the appearance of different nuclei to do the good interpretation of the X-ray. And you see that the radial head as is ossification nuclei at the age that appears at the age of 3 or 6, between 3 and 6, and the OLECRANON between 8 years and 10 years. This is important to not to avoid mistake in the diagnosis of a simple X-ray. So you have to know that, and it's not very complex, but you have to know the age of apparition of these ossification centers. There are many axes to know on the radius, many angles, but today the most important axis to know is the long axis of the radius. As I told yesterday, remember that the long axis of the radius must cut the capitellum, the lateral condyle, in the middle third, as on this X-ray, sagittal X-ray. but also as on this coronal X-ray. And on this X-ray, on the whole X-ray, even if the incidence is not very well, this axis must transect the capitellum. It is very important, and we will see that on all the topic concerning the forearm. So let's begin with the radial neck fracture. The radial neck fracture is 5% of the children fracture, and in 50% it is associated with other injury, medial epicondyle, olecranon, elbow dislocation. And the radial neck fracture is also often associated with lateral condyle fracture, because the mechanism is that the radial head push on the humeral distal bone, and there are often associated fracture. The main age is 4 years old to 15 years old, and it is always a Salter 1 or Salter 2 fracture or purely metaphyseal fracture. The important thing to remember is that there is almost always periostome between the epiphysis and metaphysis, which remain intact. And this intact periostome is very important. Why? Because we must avoid to do damage of the periostome with direct approach when we do surgery. We must avoid surgery, or if we do surgery, we must try to do intramedullary nail surgery or percutaneous surgery. So the mechanism is when the kid falls on the end with the elbow in valgus, and as you see, there is a bump between the proximal radial head and the lateral condyle. As the classification are numerous, but the most convenient classification is the classification of Judet, with a grade 1 non-displaced, grade 2 displaced minor to 50%, or angulation minor to 30 degrees, as on this slide. The grade 3 is an angulation major to 30%, or minor to 60%, 60 degrees. And grade 4, the angulation is major to 60 degrees. So with this classification, it is easy to explain that the first grades, grade 1 and grade 2, are sometimes and are often non-surgical cases, but grade 3 and 4 need surgery. Also, sometimes we have not metaphyseal fracture, but Salter 2 fracture, but it is exactly the same problem. Here you see a Salter 2 fracture of the proximal radius. The treatment is in the grade 1 and grade 2 immobilization without surgery, and the casts must be in place 4 or 6 weeks. It's a relatively long period to obtain consolidation, and in the cast the end must be in pronation. In the grade 3, you can tend to do a reduction when there is a too important translation, more than 50%, or angulation major to 30 degrees. And in case of failure, you have to do surgery, and this surgery is, if possible, percutaneous or wiring with an elastic centromedullary nail. In this case, as nail, we use a Kaiwa diameter 1.6, for example, or 2 millimeter. In the grade 4, there is no discussion. We have to try to do a wiring, if possible, without direct approach. So we use elastic nail as a Kirchner wire. An example of close reduction, you see this girl, 6 years, with an angulation at 45 degrees. When you push the epiphysis, you obtain a reduction. And when you push with your thumb, the thumb of the surgeon, push the radial head, and we can obtain, in most of cases, a satisfactory reduction. You don't need to have a complete reduction, but if you obtain a reduction with an angulation minor to 30 degrees, it will be okay, and you can do the plaster cast for 6 weeks. And if not possible, it is easy to do a wiring with the principle of elastic intramedullary wire. You introduce the Chi wire in the metaphysis, and you push the wire in the radial head. You do a rotation, and you reduce and fix in the same time the radial head without direct approach. It's the most. It is the better technique to avoid the section or the damage of the periosteum of the radial head. There are complications in this fracture. Immediate complication is the radial palsy. It's very rare consideration, but it exists. But the most important complication is the radial head necrosis, when there is a high displacement, or when you will have to do a direct approach. If you do a direct approach, you are exposed to a radial head necrosis. This is an example of radial head necrosis with a radial head which is completely flat and with irregularity of the articular surface. Another example, the radial head has completely disappeared, and this is typically the kind of necrosis after direct surgical approach. That's the reason why we prefer to do approach with the wrist and with the Chi wire, that we do an indirect approach, non-direct approach of the radial head. Don't touch to the radial head. Other example, it's not an intramedullary fixation, but it is a reduction associated with a fixation through the lateral condyle. But unfortunately, we obtain a radial head necrosis. It was not possible to have correct vascularization of the radial head. Secondary complication is the pseudarthrosis of the radial head, and in this case you see that it is a classic case, but appear of pseudarthrosis, and this pseudarthrosis has a secondary effect, and the secondary effect is the cubitus valgus, ulnar valgus of the upper limb, and during a few years the function is normal, but after a few years so there are often pain of the elbow and stiffness. Concerning OLECRANON fracture, the frequency is also 5%, and the age is around 9 years, and it is typically a metaphyseal fracture. It would be flexion fracture, extension fracture, shear fracture, and it could be a displaced or non-displaced. There is a classification that differentiate a fracture parallel to the physis, or vertical, or oblique, and sometimes it will be one fracture, but sometimes there is a comminution. Well, in such fracture, when there is a section of the olecranion, you have to do surgery to stabilize the olecranion and avoid secondary displacement. and you can fix with wire and suture. You can fix with screw if the kid is a little bit older, but the most important thing is to obtain the continuity of the extensor of the elbow. When there is an undisplaced OLECRANON fracture, you can do only a plaster. This is an example. You have a vertical fracture of the OLECRANON, and after 4-week cast, there is no problem. And you see at 6 months follow-up, you don't see the fracture except this little osteophyte. But sometimes when there is an important comminution, as in this case, you see here the fracture, you could think that it is only a vertical fracture, but if you see the coronal plane, you can see that there is a separate metaphysis, and you need to do osteosynthesis to stabilize the OLECRANON. So you have to check the X-ray very closely, and if it is a real comminution of the OLECRANON, this is the most important fracture, don't hesitate to do plate. The advantage of the plate is that all the fragments are support and stabilized by the plate, and you see the result at 10 months with a normal function of the elbow. There are not many complications, sometimes malunion, but when you operate the patient and if you do stable osteosynthesis, the pseudarthrosis is very, very rare. The gross disturbance is never a big problem. This provides a short OLECRANON, but the function is normal. To end the chapter on the elbow, we must speak about elbow dislocation. The frequency is 3% of elbow trauma, and the age is between 11 and 15 years. It's older than a supracondylar fracture. Usually, we say that in the little kid, there is a supracondylar fracture, but in adolescence, the bone becomes stronger, and the patient made elbow dislocation rather than supracondylar fracture. The mechanism is the fall on the end with the elbow in extension, and you see the peak of incidence. The supracondylar fracture has this peak of incidence at between 5 and 7 years, because at this age the bone is not so strong as the ligament, but in adolescence the peak of incidence is 13 or 14 years, because at this age the bone has become stronger and the ligament fail. There are a lot of classification concerning elbow dislocation. We can differentiate two conditions. First, when the proximal radio-ulnar joint is intact, and in most cases it is a posterior dislocation. The dislocation could be posteromedial or posterolateral. Other situations are very rare, anterior, medial, lateral. The other condition is when the proximal radio-ulnar joint is disrupted. The prognosis is poor in this condition, and we must differentiate when the condition is that we have divergence between radius and ulna, and in this case you can have anteroposterior displacement, mediolateral displacement, and sometimes you can have radio-ulnar translocation. The OLECRANON is on the lateral condyle and the radial head is on the trochlea. The most important thing to remember is when there is an associated fracture. You have to know that there is an avulsion of the medial epicondyle in 30 on 35% of cases of posterolateral dislocation. So you have to check very carefully on the X-ray if there is not the lateral epicondyle incarcerated in the joint. But also you can have a radial head or coronoid process fracture associated with luxation, most rarely OLECRANON, trochlea or lateral condyle. In this X-ray, you see the lateral epicondyle associated with the lateral dislocation. Here you see the medial epicondyle, which is also fractured and displaced. Here you see in this localization of posterior dislocation, the medial epicondyle, which is incarcerated in the joint. The treatment is when you are sure that you have isolated dislocation and orthopedic reduction, but if there are associated fracture, you have to do open reduction to treat the fracture. One important point is in the reduction technique. In case of posterior dislocation, the elbow is in extension, and you have to do first an hyperextension. You must not do a flexion, but you have to do an hyperextension to reduce the OLECRANON in the trochlea, and then after, when you have reduced, you can do the flexion. So very important to do first hyperextension to obtain a good result. After this stabilization, an immobilization of 3 weeks is necessary. And this is an example of posteromedial dislocation. And you see the result of 15 days with a very good result. There is no fracture, there is not associated fracture. And it is typically a pure posterior dislocation without any problem. Another example, in this case, you have a posterior dislocation, but you see this bone. This bone is a medial epicondyle. This is the case that I have shown to you just before, with a lateral epicondyle disrupted and medial epicondyle disrupted, and you have to do surgery to fix the medial epicondyle with cam wire, and the result after 8 weeks will be okay. Another example, you have done, there was a dislocation, the reduction was performed, and after reduction, you see that the medial epicondyle is incarcerated in the joint. You can see that on this 3D CT scan. And you have to do surgery even if the dislocation is reduced, and you have to search the medial epicondyle and fix this medial epicondyle on the distal humerus at its wrong place. It's a normal place, sorry. The complication of ulnar elbow dislocation. First, neurology complication. It is 5 to 20% of cases. It concerns ulnar nerve in case of posterior dislocation and medial epicondyle fracture. In such condition, you can see you can understand that the medial epicondyle is displaced. And the medial epicondyle is very close to the ulnar nerve, and in this condition, there is it could appear palsy of the ulnar nerve. In most of cases, it's only a temporary palsy, and it will recover spontaneously. Lesions of median nerve are rare. It is the same case for immediate vascular disease. Sometimes you have temporary ischemia, but first of all, you must do the reduction of the dislocation. And if you do the reduction, in most of cases, the end will become pink, the vascularization will recover, and you have to wait a few hours to be sure that there is an ischemia, or to be sure that the pulse, the radial pulse, reappears. And if it reappears, there is no problem. If not, you have to do arteriography, or you have to do CT and angiography, and if necessary, repair the artery. A progressive complication is a compartment syndrome due to a delayed treatment. If the dislocation remain 1 or 2 days before treatment, a compartment syndrome is possible, and you have to associate to the reduction and a wide opening of the aponeurosis of the forearm. Late complication is stiffness. It is frequent, but if you wait 1 or 2 years, you will obtain a recovery of the function. Other complication is the periarticular calcification, medial or lateral, sometimes anterior. You know that these calcification are favored by massage and forced elbow extension. So avoid any massage after elbow dislocation, because there is a high risk of calcification. Now we can see the Monteggia fracture. It's a very important chapter because there are often mistakes on these fractures in children. It was described by an Italian surgeon, Battista Monteggia, in 1814. He describes the anterior dislocation of the radial head 1 month after the removing of a bandage. At this time, surgeon did bandage, but not cast. It is almost 2% of forearm fracture. So you will see Monteggia fracture necessarily during your career. The mechanism is what we say bad boy fracture. The most frequent mechanism is when you place your arm on your face to protect your face, and there is a direct trauma on the forearm, on the ulna, and there is a fracture of the ulna and the dislocation of the radial head. There is also an indirect mechanism with when you fall in hyperextension and hyperpronation in the end. There are several types. The type 1 is a classic historic type with a fracture of the ulna and the anterior dislocation of the radius. And it is in this case that on the X-ray, the axis line of the radius is very interesting, because you see that the epiphysis of the radius doesn't cut the capitellum. Type 2 is when there is a flexion, and in such cases, the radial head is dislocated in a condition of posterior dislocation. And in most of time, it's proximal or medial third of the ulna, which is disrupted. In the type 3, in adduction, the adduction provides an external dislocation of the radial head. And in the type 4, there is it is as the type 1, but there is in the association on the radius of a fracture and a dislocation of the radius. And it is a problem, because in this case, it is very difficult to place the radius in the good position. the first treatment in Montegia fracture is the orthopedic treatment. Here you see a lateral dislocation of the radial head. I draft the long axis line to show you that it is very important to do this line on your X-ray. Here you see that the axis of the radius is lateral to the capitellum, lateral and posterior. It is due to the fracture of the ulna. It is a greenstick fracture, and you can do the reduction of the ulna, and you see that when you have done the reduction, the axis is on the capitellum, and you have treated your patient with the good treatment. You have to check on the X-ray under the cast that there is no secondary displacement very carefully. So another case with the same fracture and with a reduction, you see that we obtain also a good result and a good reduction of the radial head. Here the radial head is dislocated, and after reduction you see that the radial head is coming in the good position, and sometimes your interest is to do the reduction with a little overcorrection, as in this case you see that the surgeon, when he has done the reduction, has done an overcorrection of the ulna to obtain a good reduction of the radial head. But sometimes you see that we need a surgery. If you don't have a good reduction of the radial head, you have to do a surgery. So you see this case with an anterior radial head dislocation associated to a fracture of the ulna, and the surgeon has to do an osteotomy because it was a late diagnosis, and this osteotomy, you see, provide an overcorrection of the ulna, and this overcorrection of the ulna with help the interosseous membrane to reduce the dislocation of the radial head. So here you see the ulna, and then you see that the surgeon made an osteotomy of the ulna with an overflexion of the ulna, and the interosseous membrane reduce the radial head. You can also associate a fixation of the annular ligament around the radial head to do a ligamentoplasty. That's what I have done with this anchor, and I have stabilized a little bit more the radial head to be sure of a good result. Another example, this is in emergency. You have an anterolateral dislocation, and you see that there is the recent fracture of the ulna, and after plating, the ulna spontaneously comes. There is no necessary, in most cases, to do direct approach of the radial head. The lonely correction of the ulna allow, in most of cases, the reduction of the radial head if you are in emergency or a few days after the fracture. If it is too late, in most cases, you have to do direct approach of the radial head, but at the first stage, osteosynthesis is not necessary. This is the result at 8 months, the result at 1 year with a stable radial head, stable elbow, and a good result. So remember that you have to check very carefully the radial head in all the forearm lesion of the kid. Now, proximal midshaft forearm fracture. It is very classic. You have seen a lot of fracture as this one, and sometimes very spectacular fracture with a high displacement. And the treatment is very important to understand. It is very frequent, 45% of all fracture in children. 25% are located on proximal and mid-shaft forearm. And these fractures are very frequent, but there is a high level of complication when it appears after 8 years old. Why? Because there is not a great possibility of remodeling bone in this kind of fracture. You must remember that there is a high possibility of remodeling bone in the wrist, and when it is a metaphyseal fracture or an epiphyseal fracture of the radius and ulna. But in the proximal and medial shaft of the radius and ulna, there is a poor prognosis concerning remodeling bone. You must remember that, because every time you will have to decide to do a closed management or to do intramedullary nailing. And when you have to decide if you do surgery or not, you must remember that in the proximal part of the forearm and medial part of the forearm, you cannot expect good remodeling bone. And this is the reason why I think that if there is any doubt, you have to do intramedullary nailing. The mechanism injury is direct trauma, and there is soft tissue damage in this case, and a risk of compartment syndrome. But it also can be an indirect trauma, and the most common in when the kid fall on the hand. If you have considering anatomic consideration, you must know the displacement technique if you want to do orthopedic reduction, and you must know that the displacement depend of the level of the fracture and the insertion of muscle on the forearm. If you don't obtain an accurate reduction, and if you don't have an anatomic reduction, there is a high risk to compromise the prognosis concerning pronation and supination. And you must also know that pronation and supination do not allow, you must remember there is not possibility of remodeling consideration concerning pronation and supination. And this is a transversal displacement, transversal malunion. And if there is a malunion in the transversal plane, there is not possibility of remodeling bone. This is very important in this kind of fracture. So there are different fractures. You know the classical greenstick fracture with only one cortical which is disrupted, and it is typically the case that it needs close reduction. But in most of cases, it is a complex fracture, displaced or not, and sometimes with complex deformation, angulation, and rotation. Here you can see an example. And in such fracture, if you don't obtain good reduction, you will have to do immediately surgery. Take care in any time of the risk of Monteggia fracture and the risk also of distal radioulnar joint. So when you check fracture of the forearm, you almost have to obtain on the X-ray the elbow and the wrist to check the possibility of dislocation. We have already speak about that in the Monteggia fracture. Also, fracture typically in the kid is a plastic deformation. The plastic deformation is in the young boy or girl, and in the young kid, it is possible to have deformation of the bone without fracture, and it is a classic pitfall. You see on this picture deformity of the radius and ulna. You see on this X-ray that there is a fracture of the radius, but there is also a plastic deformity of the ulna, And if you don't correct the deformity of the ulna, you will not obtain a good reduction of the radius. So remember that the child can have plastic deformation without fracture. So what is the treatment? For all the fracture, you can attempt a close reduction, and you have to attempt close reduction under general anesthesia or local anesthesia if it is only an angulation. But the technique is different for each type of fracture. And if you are not sure of your reduction, if you have the sensation that the reduction is not stable, if you have the sensation that you will not be able to check every week the patient, so it is better to do an elastic stable intramedullary nailing. In case of greenstick fracture, the intact cortical must be broken to prevent recurrence. The deformity should be slightly reversed, and after a long arm cast with the wrist in neutral position is played for 2 months. 2 months is very long, and you have to remember that the middle part of the forearm has a poor vascularization, and the consolidation is long. The cast must be kept a minimum of 2 months, and sometimes this is the reason why we do elastic intramedullary nailing, because if you place such nails, you do not need a plaster cast, and it is sometimes a very important condition. So you have to check the reduction. If you do reduction every week during the first 3 weeks, and you can obtain good result. As in this case, you have a greenstick fracture, and we do the reduction, and you see the result with a perfect function. When you have complex displaced fracture of the bone, a close reduction is difficult, complex, even with a good experience. The technique associates longitudinal traction, overlapping and reposition of the fragment in anatomical reduction. The forearm must be maintained after in the most stable position for the fracture, and with a long arm cast during 2 months, and if it is an adolescent, 3 months. So you see that the treatment is not quite easy and evident. An example with a high displacement, and the reduction was very good. So we don't touch, and we check the patient. Here you see at 15 days, the result is okay. And you see that at 4 months, we have a good result. So the reduction is possible even if you have an important displacement. But if there is any secondary displacement, if you have any doubt concerning the stability, don't hesitate to do conversion in surgery. Another example with translation, and you can do reduction with traction, and you can push the fragment, the distal fragment, and you see at 15 days, at 3 months, the result, and after you will obtain a good result at 3 months with a normal pronosupination. But you see this patient has a middle third fracture. You don't obtain good reduction when you do local anesthesia, when you do general anesthesia. So you prefer to do elastic intramedullary nailing. You don't need cast, and sometimes you place a cast during 7 days to be sure that the kid will not be painful, as is in this example, and it will be okay. 1 month later, no cast, normal school life, and 7 months later, everything is okay. The nail must be removed after 6 months. You must keep the nail 6 months because there is a high risk of recurrence of the fracture if you don't remove the nail at this time. So you know the technique, and it will be explained by Pierre Journeau in a future lecture. You introduce the nail in the metaphysis, and you try to cross the fracture with the nail, and so you need radioscopy, C-arm, and if you don't have C-arm, or if you cannot cross the fracture, you open the fracture and you see your pin crossing the fracture. And after the radius, you do the ULNA, and it is the end of surgery. You see the technique with a small approach of the ULNA and the radius. Here, for example, you have you made the hole in the OLECRANON and in the proximal OLECRANON, and after you introduce your pin, and with experience it is quite easy. If you don't have to have a skin problem, you have to bend very carefully the two chiral, because if you don't have special in a nail, titanium nail, you can do this surgery with simple chiral diameter 1.6 or 2 millimeter. Another example, you see the first stage trauma with high displacement, and you see at 5 months there is a good result with elastic nail, and at 6 months we remove the pin, never before 6 months. The benefit of this stable nail is a small car, the absence of open reduction when it is possible to have a C-arm, a rapid union, and a normal life without casts, and it's very important for kids to go to school. The risk is at evidence osseous infection, sometimes other complication, but it's very rare. Concerning fracture of one bone on the forearm, sometimes there is just one bone fade. In case of fracture of only one bone, in my opinion, it's possible to do close reduction, but it's most important to do a surgery, because when there is one bone, the consolidation is very long. If you have an intact bone, if you have a fractured bone, the consolidation is too long. And if you have an elastic nail on the bone, you are sure that you have the good position, and the kid can move, and you can wait consolidation very, very long time without risk. In case of plastic deformation, the reduction must be done very carefully, and you must break sometimes the bone to be sure that there is no recurrence. You see that there are a lot of complications in case of close reduction. The first is, in my opinion, the displacement. You have in the different lecture and the different papers 7% to 25% of secondary displacement. You have 16% of malunion, and you have a poor correction of the defect of prosupination, and remember that you don't have a remodelage in case of a defect of prosupination. You cannot expect a spontaneous correction. You obtain spontaneous correction in angle defect, but not in a defect of prosupination. And the particularity of the forearm is that you can have a recurrent fracture due to, in most times, the insufficient period of immobilization. Remember that forearm fracture is long to consolidate, and your cast must be kept 2 months. And if you don't want to have a long cast period, you have to do surgery. An example, closed reduction cast, you do the control history at 7 days and you see a displacement. You must not wait. You do intramedullary bone. You just keep the cast 7 days and it will be okay. This is a very classic condition, and you must explain to the parents when you do a closed reduction that there is a risk to do surgery after 7 days or 15 days to be in case of secondary displacement. And you see that with this boy, we do a close reduction, and 2 months later we had a correct result. So everything is possible, but you have to know very well the technique of the intramedullary nailing to be sure that you will not have a bad surprise after 2 months. So one of the problem of the forearm, and I will end the chapter with this problem, is the recurrence of fracture. So see this patient, close reduction, as I said, we have a good results 2 months later, everything is okay, but with at 9 months later, we have a recurrence fracture. And you see that the fracture is at the same place. And it is classic complication of the forearm fracture due to the poor vascularization of the diaphysis. And you see that the treatment of the recurrent fracture, we didn't try to do reduction, and we perform intramedullary nailing with a good result. Other possibility is pseudarthrosis. Here you see that a pin was placed on this fracture. It's not an intramedullary pin, but a intrafocal pin. And we didn't obtain reduction with this poor treatment. And there is an evolution to a pseudarthrosis. And in such cases, and only in such cases in children, we place plates and screws to obtain a correct angle correction, and at the end, consolidation. So remember that the gold standard of a fracture with high displacement remained for us the intramedullary nailing, because there are a lot of advantage with this technique. So in conclusion, with the forearm fracture, close reduction must always be attended, but you have to do conversion in intramedullary nailing if an anatomic and stab reduction is not obtained, and in all cases of polytrauma, vascular injury, of pathologic bone, as in osteogenesis imperfecta. More easy is more simple is the metaphyseal fracture. As you see, the classic metaphyseal fracture in the kid, which consolidates very quickly with 3 weeks consolidation. It's very interesting to see that in the diaphysis, a few centimeters above, the consolidation is very long, 2 months. But in the metaphysis and the epiphysis, you have a consolidation at 3 weeks. Such fracture, if there is displacement, can be reduced under local anesthesia and sedation in case of simple angulation, but under general anesthesia in case of large translation and overlap. So reduction is always with the same procedure in the metaphysis or the epiphysis. You worsen the deformity, and after you do the correction, and in such with such reduction, you always obtain a correction in the metaphysis and the epiphysis. Here is an example of large displacement with a good result. But take care of the secondary displacement. You see this kid had a very displaced fracture. This is a reduction. At 1 week, it is okay, but you can see that in the sagittal plane, there is a beginning of secondary displacement. At 2 weeks, the displacement worsened. And at 3 weeks, there is an angulation of 35 degrees. So we decided to do a conversion, and we placed the percutaneous pin and a cast, and at the end we obtain a good result. So this fracture can be reduced in all cases, but you have to check this fracture every week during the 3 first weeks. Another example of fracture with an angulation, and in this fracture the reduction was not satisfactory with remaining angulation, but the angulation was in the sagittal plane. You see that in the coronal plane the axis was okay, in the sagittal plane it was not. So if the kid is young, there is a high chance of remodeling. There is poor remodeling bone in the diaphysis, but good remodeling bone in the metaphysis and the epiphysis. And you see the result at 3 months, and the remodeling process is the remodeling condition is beginning, and at the end the result is okay. You see at 1 year follow-up, everything is spontaneously corrected. So there is a high difference between midshaft and metaphysis. Concerning epiphysis, it is typically the lesion described by Bob Salter on the physis, with Salter 1 and 2 separation of the growth plate, or metaphyseal and separation of the growth plate. These are fractures with good prognosis because the growth plate is not disrupted. The Salter type 3 and 4 are a section of the growth plate, and the prognosis is very poor. But in most cases, largely most cases, it is Salter 1 and 2, as is in this example. There is a very important displacement. It is a spectacular fracture, but fracture with a very good prognosis. And when you do the reduction, sometimes you can do that under local anesthesia, because it is very easy to do the reduction. Why is it easy? Because the periosteum or the posterior periosteum is intact, and if you do a simple traction and flexion, you will reduce the fracture, and you see that the growth plate is intact, in fact, because the growth plate is completely fixed on the epiphysis, and if there is a separation, a physical separation, the growth plate remain intact. And this is the example of Salter 1 fracture, and this with this Salter 1 fracture, we will have quite easy and good reduction. In case of physical section, the prognosis is poor. It is a rare condition, and with such fracture, even if it is not a spectacular fracture, surgery will be necessary with pin or little screw to restore the anatomic condition and avoid joint disturbance of epiphysis. So you must very carefully differentiate these two conditions, separation of the growth plate and section of the growth plate. So the exam of the X-ray must be very careful in such cases. So in conclusion of this part 2, we can give you an home message. First, avoiding childhood pitfalls. There are some difference with adult fracture. And concerning this lecture, at the elbow, never ignore a Monteggia fracture. Always draw the line along the radius axis and check the possibility of Monteggia fracture. On the forearm, do not hesitate to perform osteosynthesis with intramedullary nail due to the risk of secondary displacement and low remodeling possibility. Remember the middle part of the forearm has a low remodeling possibility. At the opposite, on the wrist and the metaphysis, you can do as much reduction as possible without surgery, because on the contrary, the potential for remodeling is significant. If you remember these 3 points, I think that you have made a great progress in the management of child fracture. So I expect that this lecture will give you interesting information, and we expect to meet you again very soon in Myanmar. And I think that with Jérôme, it will be possible to see you and work with you on orthopedic surgery, on spine surgery, and with Professor Soweso. And we think about you every day in your field. Thank you very much.
Thank you. Thank you very much, Professor Ju. We had to fight. We will see you again in Yangon and the spine unit to do the scoliosis surgery together. Thank you. Thank you very much. And I think now floor is open for discussion.